So I thought I'd begin actually, although you've now actually done most of it, but just to reflect for a few minutes on the time I was a visiting professor here, which was a great experience for me. I came to Ireland a great deal when I was based at Lancaster University. I used to come over here. In fact, on one occasion I came to the island of Ireland 32 times in a year. That's probably a bit of a record anyway. Very, very grateful to the Irish Hospice Foundation because they drew me into this role. I hadn't been at Lancaster very long when I had visits from colleagues at the Irish Hospice Foundation, and Orla came, and then later on Eugene Murray, and he was very persuasive in getting me to be involved in this, and it was great to work with, and inspired a particular study which I'll come on to in a moment. It was great to work with people there, and I have to say that the Hospice Friendly Hospitals program was kind of getting up and going around that time, and it inspired me a lot because what I saw in that was something that was trying to make a big impact across an entire health and, well, essentially a social care system, and I was inspired by that, and it also helped me with some of the work I was doing at the same time, which I'll come on to in a minute. And I was pleased to hear, and I've been following the subsequent progress of hospice-friendly hospitals, that it's continuing and has really made that transition from something, an innovation that gets going outside of the mainstream system, but over time changes that system and becomes assimilated within it. And Orla was telling me at lunch that some of the key posts now are HSE funded, having again been primed in the early days by Atlantic. And something else called the Dormant Grants Fund or something, which was an intriguing pot of money that they drew on. I think the idea of what became the All-Ireland Institute of Hospice and Palliative Care occurred to me on the first afternoon that I was in the role of visiting professor. I had a meeting with Maurice Fitzgerald in the morning and then went off to a hospice in the afternoon and got talking, and suddenly something clicked in my mind that there was really an opportunity to try and bring together all those different dimensions that Regina was outlining in a way that could have a big impact. So that was in late 2005, and I've actually been looking back through my notes and reports to the Irish Hospice Foundation over the last couple of days, and I'll maybe share those with the Institute, because there's a nice story in there about how the whole thing evolved over time. And at the time it felt like a long time, but looking back it wasn't really, because the first paper I wrote about the idea was drafted in sort of late spring of 2006, and it found its way at that point to Northern Ireland, and I started getting interest from there. And by the autumn of 2007, we'd began to see this as an all-Ireland enterprise. And in the spring of 2006, in the spring of 2007, we had our first meeting here in Dublin, where we began to explore the idea. Now, everyone's very warm and friendly about it, as they should be at this stage, but they weren't so warm and friendly at the time, and there was a lot of, another term I learned, pushback, shall we say, from various sources. And in my notes and reports, it was interesting to see how these got dealt with. And I think in many ways it was a model process of consultation and collaboration that we went through. We got seed corn money from the Atlantic Philanthropies to bring in some external help. We formed a steering group. We built a business case, and then in the end, we succeeded just as the lights were going out on the world economy to get the whole thing over the line. Another phrase I learned from Eugene Murray, and which I use constantly now with my team, getting things over the line. And so in 2009, the call went out, and then the application came in, and you'll know much more about the subsequent process. But I congratulate everyone involved in that, because I hope that those who were skeptical at the beginning have now played such an active part in the development of this fantastic idea. And days like today demonstrate just how it's bearing fruit. So that's a happy time for me to look back on. But it relates to this interest of mine in a more kind of strategic system level type of approach to the challenges that we face in doing research that will support development in palliative and end-of-life care. And one area that I worked in for a while before I came to Ireland was I was appointed to write an analysis of the history and development and impact of something called the Project on Death in America, which was funded by George Soros for nearly 10 years. And I wrote a book about that, and there's a kind of blog on our site about it where I was looking back 20 years on from its formation. But I think there was things in my learning there about how you build system level and strategic change that fed into the ideas for the All Ireland Institute. And what, in effect, the Project on Death in America did was to, in simple terms, identify about 100 people across the United States who had real passion about end-of-life care and palliative care, and to turn them into what have become the undisputed leaders of the field in the USA today. Many of them are kind of household names, and there are people among them that I know some of you here in the room have worked with closely, Sean Morrison and Diane Meyer and people of that ilk. So I found it very interesting trying to understand how the Project on Death in America came about. Literally a phone call from somebody who wanted to meet Kathleen Foley, who'd been sent to do that by George Soros, to find out a little bit about how we do death in America. And one of the things that Kathy said to me about that was, she said that she always tries to make room for people in her diary who want to come and see her to talk about her work. It's a good lesson to people who feel they've got busy diaries. And so she made room for this person who was I dare say, a slightly dotty, newly retired social worker. But it turned out that this slightly dotty, newly retired social worker was, in fact, a close friend of a billionaire, George Soros, and he wanted to get involved in this, and it led to a $45 million investment over a 9-year period. So there's a lot in that influenced my thinking about the All Ireland Institute, but in particular there was a lot in that about this interdisciplinary approach and how you bring together, as the PDIA did, clinicians of various stripes. And there were psychiatrists, there were pediatricians, there were physicians, internists and surgeons, but there were also social workers, there were some social scientists, and there were nurses as well. And cultivating among that cohort of people a sense of ability to make change was fascinating to study. And some simple metrics that came out of it was the amount of grants that they leveraged compared to the relatively small amounts of money that had been invested in them in earlier points in their career. So that's one area where I think this kind of interdisciplinary research plays out rather well. Another one that's interested me a lot recently, and it's been mentioned already this morning by Phil, is the World Health Assembly resolution. In our own study, which I'm going to come on to later, we've just been doing a small project to try and make sense of the initial impact of the resolution 3 years in. We've, in fact, interviewed all the people who were instrumental in it coming about. And there's no doubt it took a long time to get that resolution through. If you think back, the WHO first defined palliative care in the late 1980s, and it took till 2014 for the World Health Assembly to make a resolution about it. So the progress was slow. But one of the things that played into that resolution getting onto the table and then being accepted in a small way, but I think in an important way, was the mapping work that was again alluded to earlier, and which I started when I was at Lancaster University. Because in those studies, what we were able to do was to build up, using a rather crude set of categories, a sense of how every country in the world is developing its palliative care systems from those that have nothing at all to those that are at a fairly advanced level of integration with the wider healthcare system. 234 countries that we've done that for on 2 occasions in 2006 and 2011. So this has given us a world map of palliative care, peer-reviewed papers containing the results, and then WHO embracing that as a crucial evidence base upon which they could make a claim for and make a statement about the need for governments all around the world to make plans and provision for palliative care. The world maps weren't the only show in town. I wouldn't like you to think I'm saying that, but I think they were very, very important to the World Health Assembly resolution going forward and the acceptance of the technical people at the WHO that there was a case to be made that could be understood through the lens of these world maps. And then the other area where I've sort of fallen into the world of policy making as a researcher, which has been extremely satisfying for me in the last few years, is in Scotland, where in 2017 we launched our strategic framework for action on palliative and end-of-life care. It's the document that follows on from the living and dying well strategy that covered the 5 years before that. And it was a very unusual position for a researcher to be in. I knew that the Scottish Government was planning to initiate a new strategy. I'd been using my blog to encourage them to be ambitious. I was hearing sort of ideas coming out in the sort of margins of meetings about how it was being approached, and I was sort of fairly boldly was sort of being critical about the lack of vision that I could sense was happening. And I think, again, it shows what you can do as a researcher if you have a bit of courage to stick your neck on the block or be a bit opinionated. Because not very long after that, I got a visit from somebody from the Scottish Government. It wasn't late at night, and that kind of visit. It was a very pleasant visit where they said, "Look, we've heard what you're saying. We're interested in your approach. Will you come and join us?" So it was, come inside the tent sort of thing. And they appointed me into the role of what they call consulting editor of the strategy. And I did 2 things. I helped to write the strategy. If you look at it, there are 10 commitments in the strategy, one of which is to create something like your PCRN in Scotland. And that has indeed gone ahead, and Scott Murray and Bridget Johnson are chairing it. We were able to insert that and other things into the 10 commitments. I also wrote an evidence summary to support the framework. And in parallel with it, the Scottish Parliament invited me to write a paper on palliative care indicators for an inquiry they were holding into palliative care in Scotland. So I've had this really fortunate position of being able to get inside the policy-making process. And some of the things I want to say about that today rather go against some of the messages of this morning about complexity. Some of the things that I want to refer to really involve simplicity and being simple about what you're trying to do and getting your message across. But it's been very, very interesting to have, as a researcher, to find ways into these high-level and strategic system-oriented approaches. And I think as a research community, we have a great deal to offer these processes, but most of the time we don't make ourselves available, or make ourselves available in ways that are seen to be useful to politicians and policymakers. When in 2017 I wrote the paper on indicators for the Scottish Parliament Health Committee, I had to present it to the committee at the Parliament, and it's all kind of live on television, and it was quite a technical document about indicators, and I was expecting a lot of technical questions to be fired at me. My team back at the university were watching it live on the, on the internet and things. I felt under a bit of pressure, but when I sat down, I was thanked for my report, and then the various MSPs weighed in with their questions. And they were incredibly difficult questions to answer, and I'm sure you would have struggled with them just as much as I did. There were things like, tell us, Professor Clark, what is palliative care? Does it differ from end-of-life care? Who gets palliative care? What benefit do they derive from getting it? And who's not getting it that should be? Those were the questions that was being asked. Not all my fancy indicators of development and outcome measurement, and very simple questions. And this was a real wake-up call for me, because I began to see the power then of trying to respond to that and produce things that would be intelligible and of interest to politicians and policymakers. And I think here on the island of Ireland, both in the north and the south, you have that same kind of arrangement that we have in Scotland, where you're relatively close to policymakers, politicians. You live in a relatively small society where you meet people and you can engage with them, and you have fora in which to do that. The key then is to be bold about what you can offer, and my message really as I go through is keep it simple. So 2 studies that don't relate to my sort of current bigger program of work, but which I wanted to flag up just quickly. The first of them owes its origins to here, because it was an idea of Eugene Murray's. He wanted to find out in Ireland how many people who are in hospital are in their last year of life, and he discovered it wasn't possible to get the answer. In fact, Charles Normand once told me that the study that would be required to do it was at that time illegal or couldn't be done for both technical and legal reasons. So we actually did it in Scotland, and it's been a very, very powerful study for us, and I wanted to flag it up for you, along with another one that we've done more recently, where we ranked palliative care in Scotland in development against other countries of the EU, bearing in mind that Scotland will be staying in the EU, even if other parts of the so-called United Kingdom have decided to leave. And I put these 2 things up. Do anybody know what those little donuts are? Does anyone know? Altmetrics, yeah. I didn't know anything about these, and when this paper, which on the imminence of death appeared in Palliative Medicine, it very quickly got an altmetric score, and I found out about it. And so I phoned up our Pro Vice Chancellor for Research, and I said, you need to know about this thing, altmetrics. And he said, have you looked on the university's what we call Enlighten, which is where we list all of our publications? He said every publication has got the altmetrics score against it now. Well, what altmetrics does is it measures the amount of social media interest in your publication. And we did very well with our first paper in this respect, because we built a plan around its launch, press release, and we worked closely with the journal. But we were just really accidental beneficiaries of the altmetrics. But now we work hard to plan when papers come out on altmetrics and how we might influence it. So the imminence of death paper published in 2014 in Palliative Medicine has an altmetric score of 267. It's the second highest ranking altmetric score of 1,300 papers in Palliative Medicine that have an altmetric score. And then the second paper here, which I'll come on to in a moment, has an altmetric score in the BMJ Supportive and Palliative Care of 203. That paper only came out this year, and it has the highest score of any altmetrics score of anything that's ever been published in BMJ Supportive and Palliative Care. So you're really following on from these points about knowledge exchange and transfer and so on. Altmetrics is a very important tool, and it's also said to be quite a strong predictor of more formal citations. So what were these studies about? Well, they're both very simple. The idea was to look at everyone in hospital on a single night in Scotland, which we originally did for a date in March 2010, about nearly 11,000 people in 25 hospitals. And then we linked the hospital records, I say we, somebody cleverer than me did it, to the death registration records 1 year after or subsequent to the census date, as we called it. And what we found was that almost 29% of people in hospital that night had died within a year. And that in fact, over 9% of those in hospital that night died before they left the hospital. Almost everybody in the Scottish media, and it was very, very widely reported, got this right. So the only person that didn't at the time was the health minister, who thought this was a kind of an attack on the quality of care in hospitals. In fact, it was just the opposite. It was really, and people now understand this, drawing attention to the fact that our so-called acute hospitals are really places where end-of-life care needs to be happening and where we have a wonderful opportunity to identify and reach out to people and begin conversations with patients and families about end-of-life care concerns, needs, preferences, plans, and so on. So it's a wonderful tool for advocacy for end-of-life care in the hospital context. And I wish I had a sort of a euro for every time somebody has said to me, oh, David, I was at a meeting recently in such and such a hospital or such and such a clinical setting where this slide came up from your study. I mean, every clinician in Scotland now seems to know this slide because what we showed was that this almost 30% of people who died within a year was heavily influenced by gender and by age, so that when you look at the oldest men, it wasn't 29% who died in a year, it was 54%. I mean, this has become so well known in the Scottish context that people ring me up at the university and say, David, I'm going into hospital for a knee operation, should I be worried? And I said, no, if you read the paper carefully, the surgical group had much lower mortality than the medical admissions. But it's a devastatingly simple study, which has had a massive impact in Scotland. And we repeated it for a census date in 2013. And we got almost the exact same result. That Kaplan-Meier curve on the right shows that the two populations were almost identical. So what we've been doing is saying, you know, we're in a settled state, a settled pattern in our hospitals in Scotland now with this situation where almost a third of inpatients on any given day are in the last year of life. And this is a really important opportunity for advocacy and identification, the kind of work that Scott Murray and others are doing to really drill down and identify these patients, not as we are doing, rather simply with the retrospectoscope. You know, it's quite easy to work out who's died subsequently. It's more difficult to identify those patients prospectively, but that is the challenge, and there are ways to narrow down on those groups. The studies had a lot of interest across the UK and particularly in Scotland. It's been repeated now. The second study was repeated using the same census date, 10th of April 2013, by Merrin Gott's team in New Zealand, and that paper's just been accepted for publication in BMJ Open. And we also collaborated with the team in Denmark and repeated the study there using the same census date. So it has real power. And I don't know, and maybe you can find out whether this study could now be done in Ireland, but the idea began here, and it would be wonderful to see it done. But it's an example of a clear message. You'll all go away, I hope, remembering this study and remembering the result. And this is what we need for the kind of elevator pitch that's going to influence policy. A thing that came out of the Scottish Parliament inquiry was questions that were put to me about how well is Scotland doing in the delivery of its palliative care. And we weren't able to answer that question, and we realised there was actually very little information about the provision of palliative care in Scotland in terms of services and types of services and their distribution. So last year, we, again, working with the Scottish Government, we produced a Scottish Atlas of Palliative Care. Some of you may have seen it. You can download it from our website. And we then by using the data from which we'd created the Atlas, we were able to fit the data for Scotland on inpatient units, hospital support teams, and home care teams into a model that we'd already developed with colleagues in Pamplona at the University of Navarra, Carlos Centeno and his team, whereby we'd ranked the countries of the European Union in terms of the delivery of specialist palliative care services. And what the Scottish politicians wanted to know was, where does Scotland fit into that picture? Because we have a ranking for the United Kingdom. So we kind of proceeded, the methodological stance of this paper was Scotland's an independent country. We fitted the Scottish data to the model. And quite interesting, actually, to see, I've highlighted where Scotland is in the top 10 on all 3 categories. Ireland's in the top 10 on 2, and rather annoyingly sits above Scotland on those 2. But for some reason, Ireland isn't in the top 10 on the ratio of inpatient units per million of population. Though when you combine these measures together, it sits in the top 10 overall. So again, quite simple things, but making a big impact with wider audiences, social media, traditional media, journalists, politicians and policymakers, giving them answers to questions they are interested in, filling gaps in their knowledge. And what you find is these kinds of papers then start to crop up in debates in the Scottish Parliament and are referenced and become widely known. So that's been some of my recent experience around the policy area, just in our kind of local context in Scotland. But what I'm really wanting to focus on, and I'll go quickly now, is the much wider issue of global death and the issues and challenges that we're going to face in the global context in relation to end-of-life issues. This slide was put together a year or 2 back by people associated with the Wellcome Trust, and what it is an attempt to work out how many people died in the course of the whole of the 20th century by cause of death, and it's 5.5 billion. The reason I like to show it is because in the whole of the 20th century, 5.5 billion people died, but in the world today, 7.5 billion people are alive. The world's population is growing and it's aging, and the two are linked. The reason the world's population is growing is not because of increases in the birth rate. Most countries have a declining birth rate, but even in the poorest countries, the children that are born now have a much greater chance of survival, and many will live into old age. And we know that the population growth is being driven by that. And it means that we're facing this great, you might call, tsunami of death and dying and bereavement around the world over the next 2, 3, 4 decades. Currently 56 million people dying in the world. A lot of estimates suggesting that will go up to 90 million by mid-century and beyond. So this was my starting point for thinking about an interdisciplinary research application to the Wellcome Trust. And I was lucky enough to be successful in my application, which I made in 2014. A good piece of advice here was when funders go out and explain to researchers about their funding streams and how to apply to them, go to their meetings and write down everything you learn. The Wellcome Trust did this for their awards in the social sciences and humanities a few years ago. I went to the meeting, it was actually in Glasgow. I wrote down everything. I did the ethnography, I just had like thick description field notes of the entire thing. And then when I came to write the grant application, I just methodically went through everything with a highlighter pen. Every time I've done that, I've still got this to do. I did every darn thing that I'd learned that day and tried to put it into my application to ensure that the things the funders were looking for were there and were clear and were visible. And what the Wellcome Trust mantra is essentially is, why you or your team? Why this issue? Why now? And what difference will it make? And I think we are not too good at answering these questions in the palliative care world. We're getting bogged down in minutiae and details, and the bigger questions are getting lost. And in fact, we have a huge amount to contribute when people ask us, why you? What is it that you're trying to address, and what difference will it make? The Wellcome even now add, what difference would it make if you didn't do it? What would be the risks if you didn't do your study? A very interesting question. The benefits that would be lost. So here we have a real opportunity for interdisciplinary funding with the Wellcome Trust, a very generous and open-minded funder. And these were the questions that we set ourselves in our project to try and understand how this whole field of end-of-life interventions had developed, to look at the different types and characteristics in different settings of end-of-life interventions, and to build a taxonomy from that would allow us to conduct both case studies and also more kind of critical conceptual reviews of salient issues. My argument with the paper, with this application, was that if you take the social science contribution to end-of-life care research, my sense of it at the time I was writing this 2 or 3 years ago was that much of the work is either too embedded in the field to be critical of it, or too remote from it to be useful to it. So that's the line I've tried to steer, a kind of, dare I say it, third way between these, where we adopt a critical perspective, but not at the expense of relevance. And you know, I would really urge people to think about how that can be done. If I could just give a little bit of feedback on the social justice piece this morning, I thought that Phil's introduction was inspiring and very, you know, deeply felt and thought through. I thought that each of the individual presentations was a really good piece of work, but the two didn't connect with each other. I couldn't see the theme of social justice and injustice and discrimination being worked through in the empirical studies. What we really had, I felt, was a series of studies of the type we know about specific disease groups or conditions, but linking that to the social justice theme is obviously a challenge. And I think that's exactly where we should be in our work, bringing these big conceptual ideas into play and then demonstrating through empirical studies or case studies some use of those concepts in order to shape the work. And that's the kind of approach that we're doing. So in all of our case studies, for example, I challenge the colleagues in my team to say, which theoretical framework are you going to work with in this particular case study? What conceptual ideas or theoretical ideas are going to be most relevant to this particular piece of work? Here's our team, some funded by the Wellcome Trust, some by other means. We have a professor of nursing, we have philosophers, we have a medically qualified medical anthropologist, we've got a public health person, we've got an anaesthetist, we've got a social anthropologist, and right in the middle of the picture there, Katrina Forrest is our public engagement officer. And I wanted again to come back to your point earlier, which was we took a risk with our project in building into it a public engagement person from the very beginning, full-time. It has been a challenge because in the early days we didn't really have much to engage with, and she was really, you know, pushing the researchers for content. But we have really benefited over time from her presence, and so now everything we do gets wrapped around with a plan, a strategy. We have a successful blog, Twitter account, we have Facebook, we have a YouTube channel, we have SoundCloud. Katrina can do filming and photography, sub-editing, and, you know, I would thoroughly commend this kind of approach. It's challenging for researchers and it can be uncomfortable. We've had some rocky moments in our discussions, but it's been an extremely valuable thing to have. And she's had to engage with a new field, but also with all these other disciplines. And there are more that I didn't mention, and we have a psychologist in the team, we have a geographer in the team, trying to work on these bigger questions framed for the Wellcome Trust project as a whole, using many interdisciplinary disciplines and drawing on a number of different theoretical perspectives. These are some that we found particularly helpful and have drawn into our work, and they're all bearing fruit. I mean, if I just give one little example, responsible innovation. Has anyone heard of this concept? It comes from the world of environmental research, and in Britain now the Environmental Research Council requires all grant holders to sign up to the principles of responsible innovation. It kind of came out of the whole GM crops scenario, where there was a sense that science was doing things that could be done, but wasn't thinking through the consequences of what might happen as a result. And we've taken this idea, and there's a kind of framework for responsible innovation. And I'm writing quite a detailed paper with Jane Seymour about the rise and demise of the Liverpool care pathway in Britain, where we've tried to use the concept of responsible innovation to make sense of what happened. And had there been a duty of foresight in the development of the LCP, which the responsible innovation model calls for, then there might have been a much greater chance of anticipating the problems that resulted. But it seems to me on this occasion, palliative care fell foul of its own hubris. Not its own niceness, but its own hubris, its confidence that palliative care was unequivocally something good and helpful for everyone, and who could ever possibly disagree with it. There are things that are going on outside our field that could help us enormously if we occasionally got outside of our disciplinary silos and looked at things going on elsewhere. And one that we found particularly helpful is I must attribute to my colleague Shahazud-Zaman, who's our medical anthropologist from Bangladesh, very influenced in his own thinking by Dipesh Chakrabarty, who's a post-colonial studies Bengali academic. And this has helped us an awful lot to make better sense of what is going wrong in the notion of the global dissemination of palliative care. And I can't sort of dwell on it long here. There is, I think, a very good paper based on this that we've published in Social Science and Medicine, where we use this term, the waiting room of history. But essentially, it's the notion that if you live in the developing world, everything that you're being encouraged to aspire to is a sort of an imaginary Europe. When you're asked, do you have democracy? Do you have a welfare state? Do you have a free market economy? Do you have universal access to voting, schooling? The answer is always not yet. We're on that journey. And Chakrabarty argues that the developing countries see themselves as sitting in the waiting room of history, where the train is going to come and it's going to take them to this imaginary Europe. And I think this is one of the fallacies that we've got into in the global development of palliative care argument, that we've encouraged people to think from the West that they're in that waiting room, and that all we need to do is develop models here that can be, as we often use the phrase, rolled out and transferred elsewhere. I think this is a profoundly erroneous set of assumptions about how end-of-life care can flourish and develop in the poorest parts of the world. So we focused on interventions, and we've used this very simple definition. What is an intervention? It's an organized response to end-of-life issues. And we set about, and this was proposed in the original proposal, to create a taxonomy that would allow us to sort of map the terrain of end-of-life interventions, classify them in different ways, acknowledge the existence of hybrid types and blurred boundaries that might exist between them. But really the attempt was to step back from some of the current questions that beset the field, to define the field more broadly. So we're not just talking about palliative care, we're talking about lots of other things as they relate to interventions at the end of life. And we published this in an open access Wellcome Trust journal earlier this year, a paper where we set out our taxonomy, and we were challenged by the reviewers and have been challenged in meetings and things to explain our method. Did you do a systematic review? Was it a scoping review? Was it a this review, that review? Well, none of the above. Actually, what we did was we thought about things, and we read things, and we talked as a team. And I was rather proud of this little thing that I did in one of our workshops, where we got a local artist in to try and help us think, what are interventions and what are the different types and things. So it was a kind of creative process that the Wellcome Trust understands, but journal editors don't necessarily understand. And from that, we generated a taxonomy. From the another source, we came up with this rather crucial distinction. We've created an undergraduate course at the University of Glasgow that exactly maps onto the Wellcome Trust project. So its concerns are entirely what we're doing in our project, and the people on the project teach it. And it was in the course of discussing in the first year of delivering this program, the idea of interventions with the students, that we came up with this distinction. It came from students, actually, of the difference between the focus and the locus of an intervention. And I think this is really critical, and it was touched on quite a bit in various ways in the morning here. The focus is all about the character of the intervention, its content orientation, the discourse around it, the motivations of those who are constructing it, and the particular properties it has, the goals and ambitions that surround it. We believe that understanding that focus is critical to understanding the so-called effectiveness of an intervention. I think if you can't really understand the story of the Liverpool Care Pathway without understanding the focus. But then there's also the locus, and this is the geographical context in which the intervention takes place. And what we're interested in our project is what happens when the locus shifts with any given intervention. Is the focus itself transformed in the process, and what are the consequences? So we're using this kind of model of locus and focus and transfer and translation. There's a lot of literature on policy transfer, much of which is just about techniques and tools to transfer, take something unchanged from point A to point B and implement it. But what is far more interesting is the process of translation that goes on, how the receiving locus is changed in the process, but also how the focus of the intervention is changed in that process. Now, if you take a simple example here that we're studying, well, not a simple, but a single example. There's a lot of talk in the literature about the Kerala model of neighbourhood networks in palliative care. Appear to work very successfully in Kerala, down in the south of India. And there's quite a bit of discussion about whether the model could be taken to other places, not least to Western countries. We've been studying the issue of taking the model not to Switzerland, which has been tried, or to Hackney, which has also been tried, but simply to take it from Kerala in the south of India to West Bengal in the north. And we've done some detailed work with a researcher from the Institute of Management in Delhi, where we've uncovered huge numbers of issues that come when you seek to transfer a model just from one part of one country into another part of that country, where the social and in particular the political climate is quite different, and with huge consequences for how the intervention is implemented. So these are the kinds of ways we're trying to approach this, and this is our taxonomy. I don't have time to go into it all today. You can read the paper. Some of these elements will be familiar to you, policy interventions, clinical interventions, and so on. Some perhaps might be less familiar. We've borrowed, with approval from Pamplona, from the University of Navarra, the concept of intangible interventions. We've derived our own notion of self-determined interventions, and we've included, perhaps slightly controversially, research and education as end-of-life interventions. Our point here is what we teach people and what we study are not neutral. They are also framing and shaping the world that we seek to influence. And I think in the research area, there's quite a bit of scope to reflect on why we study what we do and what we think the effect of that is. So these are our categories of intervention. We're finding people resonating with them. I'm seeing somebody next week who's read the paper and says, I'd like to apply this not to end-of-life issues specifically, but to HIV/AIDS issues. He wants to come and talk to me about this in relation to a project in Southern Africa. So we're trying to do something a little bit new and different, and trying to develop this from the initial paper in further discussions. And one way that we're looking at this is to try to clump the interventions. It seems to me that some of the interventions that we've listed, advocacy, cultural, intangible, self-determined, are things that seek to kind of illuminate the world in some way, to explain it, to unpick it, to give meaning to it. Others are less preoccupied with that stance and much more preoccupied with acting upon the world from a prior set of assumptions about what should be done. And so we've kind of made this distinction between illuminating and frames and instruments, and perhaps research and education somewhere in between. Now, recently we interviewed somebody for a postdoc with our project, and she was coming from what they call Monsoon Asia, Singapore, Hong Kong. And I mean, yes, she's in an interview, so she's done her homework. She said, I think the frames and instrument thing is terribly important in Monsoon Asia for palliative care. I was like, tell me more. She said, well, in Singapore, the whole thing is an instrument. They've worked out what Singapore needs for palliative care, and they're trying to implement it. In Hong Kong, they're using a framing approach. They're trying to elicit what people want and need, and what their perceptions and values and beliefs are, and then responding and working with that. And I said, with what consequence? And she said, well, in Singapore, it's not working, because they're just bumping up against all sorts of cultural factors that they didn't take into consideration. In Hong Kong, they're trying to work with these things and devise forms of intervention that grow out of a cultural understanding. So, to me, that was one person, but it was somebody who'd read the paper and thought about it and made an application in their local context. So what we're trying to do with the taxonomy is to develop a term we've derived from the philosopher John Rawls, an overlapping consensus about end-of-life issues. You talked about social justice earlier. This is a big preoccupation of Rawls. And what he's really saying, and I'm not expert on this, but others in my team have very deep understanding of Rawls, is that what he's arguing for is that as human beings, we will have legitimate and deeply felt disagreements on major issues in society. The challenge is to identify those areas where we have agreement and where we can suspend our disagreements and find some practical way of converging on the areas of agreement. And I think of this in particular in relation to the world of palliative care and the world of the protagonists of assisted dying. You have this very deep set of entrenched and divided viewpoints. Can some shared ground be found where there is agreement about common areas of understanding and consensus, but a respect for legitimate difference? So one of the case studies that we're doing is looking at the so-called integral model of palliative care and euthanasia in Flanders, in Belgium. And we're trying to understand more how that has arisen, what its protagonists' experience have been, what their motivations are, and crucially, what the consequences of it might be for other places. Because if, for example, you look at Canada, the legislation there allows for the assisted dying and euthanasia to be a part of palliative care provision. It is actually in the Canadian legislation. So if you take the view, and I slightly do, that it's a case of when, not if, assisted dying becomes more widespread in many different legislatures, then there's some serious work to be done about what the implications of that are for the delivery of palliative care in contexts where euthanasia or assisted suicide are legal. And maybe this idea of an overlapping consensus is some way into that kind of rather thorny and difficult terrain. So we're doing this to try and build consensus around the breadth of things for the palliative care world to acknowledge that there are many other interventions going on that relate to end-of-life issues, which are not under the ambit of palliative care, aren't generated from the world of palliative care, aren't its responsibility. Cultural interventions, the one that we are particularly interested in is death cafes. Has anyone here run a death cafe or been to one? Yeah, one person. Yeah, 2, 3, 4. I found them fascinating. Everyone seems to be slightly different that we've organised. What's strikingly similar about them all, in my experience of the ones we've done, is palliative care is never mentioned. You know, people do not talk about palliative care at death cafes. They talk about an awful lot of issues to do with death, dying, bereavement, loss, suffering, access to care, denied access. I haven't heard those words, palliative care, put together at a single death cafe. But it's a kind of conceit of the palliative care world that we are, as a community of people, somehow holding the space for everything to do with death, dying, and bereavement. And clearly, palliative care is not. And if you look at the taxonomy of interventions, you get a sense of who else is in that space. And maybe there are places where we can link up better and collaborate and work together using interdisciplinary approaches. So, to come back to the policy piece by way of conclusion, simplicity and clarity in the work that you do, choosing simple and clear research questions, trying to generate findings that can be communicated in a simple and clear way. Adopt an advocacy orientation to your research. There's a lot we can learn from the advocacy world about how to get our message across, and some of that was spoken about earlier. Use the social media extensively. It seems to me a sine qua non at the moment for communication. But also important, develop conversations and links. Get into Buswell's Hotel. Talk to policymakers, journalists, and politicians about the work that you're doing. You'll be surprised how interested they are. And the risks that go with those conversations, I believe, are outweighed by the benefits. And focus on the most important questions or the gaps. I wrote in here and I deleted it because it looked a bit cheeky. There's no room for pet projects, things you like to do. You know, we've got to focus on things that are needed, that can have an impact, where there's gaps, where there are important questions to be answered. But, and I have to say this because I'm the beneficiary of a Wellcome Trust Investigator Award, never abandon blue skies thinking. And it's something our field is desperately short of. And we need space for that as well. And I think the All Ireland Institute and the Research Network can do something to encourage that as well, the risk-taking and the blue skies approach. So those are my thoughts. I just wanted to mention a bit of a plug. Finally, last year I published a book on the history of palliative medicine in a series called Oxford Medical Histories. I've been doing quite a lot of activity around that book. I have spoken about it at palliative care conferences, but far more I've spoken about it at book festivals. And this has been a fantastic experience for me, usually in conversation with somebody who's read it. An hour of conversation and a bit of Q&A. I even did one at the Edinburgh Fringe in August. Fantastic way to get across to people who don't come to palliative care or research meetings, book festivals and related events. And then finally, I have to say this because I've just finished it, but I literally on Friday, I pinged off an email with an attachment to Oxford University Press in New York. I've just finished writing a new biography of Cicely Saunders. And it's coming out, we hope, on the 22nd of June, 2018, which is the centenary of Cicely Saunders' birth. I think through both of these books and through much of what I've presented, the value of an interdisciplinary approach can be demonstrated. At university, I studied sociology, anthropology, history, archaeology, and geography. And in various ways, all of those disciplines, plus all the things I've learned from clinicians as I've worked in the palliative care field for the last 20 years or more, have contributed to my thinking. And to be on that journey of discovery with others, getting inside their discipline, trying to figure out why they ask the questions they do and how they relate to your questions, I think is enormously invigorating. And if you can do that and then couple it with simple outcomes and measures and messages, we stand a great chance of making a difference to the people we want to make a difference to. Thank you very much.